welcome to Concussion Talk Podcast. My name is Nick Mercer. I write Concussion Talk blog, www.concussiontalk.com. You can find me on Facebook by searching Concussion Talk, on Twitter and Instagram at Concussion Talk, and you can also check out my ebook, Detour, a link to which you can find at the right side of any of my Concussion Talk pages. It's about my bike trip across Canada in 2002 and my brain injury in 2003. This is the 10th episode of Concussion Talk Podcast, and I'll be talking to Dr. Jess Schwartz, who's a doctor of physical therapy in New York City. She will announce a concussion program for physios, doctors, and others in the new year. I'm on the phone with Dr. Jess Schwartz, and I will now get her to introduce herself and talk about her work.
Hey Nick, how are you doing today?
Good, thanks you.
So basically I'm a doctor of physical therapy here in the United States, and I'm one of a few thousand residency trained physical therapists. We have a doctorate here in the US, so we're doctors of physical therapy, and I am one of the national spokeswomen for the American Physical Therapy Association, and I am a program director for what's going to be one of the world's first concussion education program for doctors and clinicians.
So what is the program and what's it all about? Jess?
Thanks for asking, Nick. So essentially, when I was going through my rehabilitation at NYU, I was in a few social media support groups for post-concussive syndrome because you kind of feel like you're going a little crazy when you have so many things going on from something so benign. My airbags didn't go off, and I've had concussions in the past, and I'm like, well, why am I not healing? As quick, 1, 2, 3 months, my third month started to get stressful. So I really started investigating, what's out there. And other than the NYU concussion clinic, there's no other concussion clinic in New York City that was as comprehensive as they had. And it completely made sense because they were identifying things from a deficit approach. They were looking at vision separately. They were looking at balance and vestibular disorders and head and neck issues, and they really have a stellar squad over there. So I actually decided to build something, and Evidence in Motion and John Childs reached out to me, and they're a fantastic company. So I said, absolutely. So it's essentially going to be a post-professional multidisciplinary program that focuses on the concussion identification, treatment, and management, fostering a rehabilitative team approach. So it's a 12-month program, so it's a full year. And we're going to focus on the latest clinical conversations of evidence-based guidelines, consensus statements, and integrating real-world experiences from patients, providers, and caregivers who have navigated the complex healthcare network of today. So essentially that's going to be, we're integrating storytelling. Because we know that there's no evidence-based medicine for concussions, so we're actually going to bring in real-life people who have actually navigated this complex, healthcare continuum that we all live in. So it's interactive and dynamic, and we're going to expose the post-professional student to some of the most influential clinicians in the concussion community. So I'm about as excited as can be for it, and we're bringing everyone in from the emergency medicine to adult neurology, pediatric neurology, musculoskeletal management, looking at orthopedic injuries, vestibular medicine, vision rehabilitation, wonderful occupational therapists, neuropsychologists, cognitive behavioral therapy, and the whole gamut, in physical therapy, of course. So, it's going to be tremendous. And the goal really is to facilitate collective competence across the healthcare continuum, so that when we are looking at this patient, we have no definition, right? We have no common definition and pathway. So when we're looking at this patient, we can have a conversation to kind of come on the same page and, hey, this is what I can do for you, this is what you can do for me, this is what we can do mutually for our patient, and try to make him or her better as best we can with what we have available. So it's going to be unique and tough, and it's not going to be an easy program, but I think people who are going to get involved with it, we're looking at physicians, athletic trainers, physical therapists, occupational therapists, physician assistants, nurse practitioners, nurses, basically anyone that has direct access to a patient. It pretty much comes down to it's not when you're going to, it's not going to be if you're going to treat a concussion patient, it's going to be when. You can be treating an ankle patient, you can be doing just a general, yearly exam as a primary care physician or a pediatrician, and then find out someone was living with a concussion. So how can we care for these people the best we can? So we prevent the mismanagement that's been happening, all over the world. How can we care for these folks well? So I hope to solve some of those questions and provide some answers.
Yeah, that sounds really interesting and really comprehensive. So.
Yeah, thank you.
Okay, and I guess now I'll ask you about you. You've had concussion?
I have. I've had multiple concussions throughout my life, especially as an athlete growing up. I played 4 sports in high school at the varsity level, and I did some club in college as well. And I actually sustained my last concussion in October of 2013, and I actually underwent about a year of post-concussive syndrome, where I underwent about 10 hours of therapy a week for about a year, dealing with the various symptoms of my concussion that really affected my whole life and my work life and social life. So yeah.
So how did it affect your work and your I guess it was social, but your work life or your school, whatever you were doing at the time?
Yeah, so I was actually a junior partner of my company. We had 4 clinics in the state of New Jersey, and I absolutely loved where I worked. And it was where I actually did my residency and decided to stay after I finished residency postdoctorally. And I became a partner in 2012 and junior partner in 2013. And it was worth the drive to work with a bunch of people that were on the same page and really passionate about what we do, helping people and helping patients. So I was actually at a stoplight in New York City, and I was actually hit from behind, and I didn't see it by an unlicensed driver. And that's how I sustained my concussion. So I actually ended up leaving work for about a year of medical leave, and I went back, and then I decided to pursue the public speaking academic route to start educating clinicians about that concussion, because I kind of went through that profound dichotomy of being both doctor and patient.
Yeah, so that's when we first connected, I guess, when you were off, not off, so it's like it's a break, but when you're resting, recovering from your.
That's right. Yeah, that's when we
Yeah,
first met. That's
yeah.
absolutely right, and you were a big part of my recovery.
Oh, thanks.
So I always hold you close to my heart there.
Thanks. So if you did, how much? First of all, how much do you know about concussion before your hit, before your brain injury?
Well, before my hit, we actually had 4 concussion clinics in the state of New Jersey. So, and I've been working with athletes my whole entire life, basically, from growing up in the Pee Wee leagues and coaching at the collegiate level and the NCAA level, and then obviously getting the doctorate and working with athletes in orthopedic residency. And I really put athletes on the spectrum from pediatrics to geriatrics because our older populations are really as athletic as they ever could be than they were before. So we're actually going to have more folks that are 65 and over in 2030 than 17 and under. So I always say athletes run the whole spectrum.
Oh, so you know a fair bit about concussion before your hit, brain injury.
Yeah, so
Uh,
I thought, right? I
yeah.
think we all
Actually,
know.
it's kind of yes. I saw your video you have on your website, your presentation you did in Denver recently.
Yeah.
So I hope I don't know. I don't know if your view of concussions has changed, but are your thoughts on treating them? But if you knew then what you know now about concussions, or what you've learned at this point through your own research and through your own research, through your own experience, how would you have done
Yeah.
anything differently?
Oh, absolutely. And I think that's why I'd like to be part of the conversation and changing how we, triage, treat, and manage these concussion patients worldwide. And I really think that you can research and you can do things in a laboratory and in the clinic for so long, but when you really experience being a patient, especially when it's an injury that challenges your whole life, from your professional to your personal to your social and emotional well-being, it really is an all-encompassing injury. So you really have to, I was able to step back and look at the view from 30,000 feet, but then I was really also right in there in the trenches,
Yeah.
going through the rehabilitation for that year.
I saw in your presentation in Denver that you mentioned that there's MTBIs, but mild traumatic brain injuries, what concussions are now called. But you'd like to differentiate between MTBI and concussion.
Yeah, I really would. I think part of the issue that we have globally is that there's actually not one universal definition for traumatic brain injury, something that we call TBI, and there's not one universal definition for MTBI, mild traumatic brain injury. And I always say that there's nothing mild about a traumatic brain injury, and there's no universal definition for concussion. So how are we supposed to educate doctors and clinicians on how to do something and kind of be on the same page, let alone the same library or floor, right?
Yeah.
If there's no universal consensus on what something is. So,
Yeah.
if I'm looking at something and, Dr. Smith and Dr. Brown are looking at something and we're all looking at the same thing and calling it something different, how are we supposed to care for our patients well and the best we can if we can't even agree on a definition? So I really would like to see that change, specifically in the mild traumatic brain injury definition, because we classify mild traumatic brain injury, and part of that is there is in the definition of it is a duration of unconsciousness. So you can have a duration of unconsciousness, someone losing conscious, so that's what we think of as someone getting knocked out, right?
Yeah.
From 0 minutes, so you don't have to lose consciousness, and most people that have a concussion don't lose consciousness. Yeah, that's huge. But 30 minutes, and there's a big
That's
difference
huge. That's
between
huge.
0 and
Yeah.
30 minutes, right?
Oh yeah.
So I think we can do better, and I think we will, and I hope to see that in the next 5 to 10 years. That we can kind of get on the same page. In terms of a definition. And that's funny that you asked me that, because just today I came across something from Doug Smith, from Dr. Smith out of UPenn, and they're working with OneMind on the preclinical traumatic brain injury common data elements, and they're trying to form a common language across laboratories, because
Okay.
there actually hasn't been one phase 3 clinical trial in research in the last 20 to 30 years that has actually gone through. And part of that is because they don't have a definition and things are too broad. So that's a great question that you asked, because I just came across that article today across my desk.
Yeah. Well, yeah, I saw a presentation. Someone talking about how and mild traumatic brain injury is only mild compared to severe traumatic brain injury. And even that, I mean, because I had a severe traumatic brain injury, but I mean, there obviously is a correlation, but there's not. It seems to be my symptoms are a lot different than most people have had concussions or mild traumatic brain injuries, as they call them often. So it's very different.
Indeed, yeah, and part of that is because of something called a Glasgow Coma scale. We
Yeah.
see that in the language and literature. People see that on the internet, I know, when they do their searches, and that's something
Four.
called a GCS, Glasgow Coma scale.
Yeah.
And quite frankly, I really call that the guessing coma scale, and a lot of folks call it the garbage coma scale. It's kind of the only thing that we've got, and we need something, so this is okay for now. But I think we can do better, because a lot of folks that are in the field and in the trenches, like athletic trainers or paramedics and EMTs and things like that, if you kind of don't have exposure to the Glasgow Coma scale and you do that often, a lot of the times we don't do that correctly, so then it oftentimes gets graded wrong.
Yeah.
So that's a big thing as well. But I'll step off my soapbox there.
Well, no, speaking of that, so can you clinically diagnose a concussion?
Yes. So concussion is a clinical diagnosis. Period. End of story.
And you personally can do that, like in your
Yeah,
work?
Yes, correct. So in the United States, all 50 states now have direct access to patients. So patients don't need a prescription to come see a physical therapist here in
Okay.
the States. There are varying factors at the state level and with insurance carriers, maybe needing a physician prescription first. But for all intents and purposes, we have direct access. So the physical therapist is part of a primary care team that we evaluate and treat patients and we refer out accordingly. So physical therapists are part of diagnosing concussion and taking a full history.
Okay. Well, this makes this question even more, I think, probably interesting. Can you, if someone walked in and said, my head hurts and I'm pretty sure I think maybe I have a concussion, what would you do first of all, or just step by step?
Sure, that's a great
Yeah.
question. And yeah. So essentially, we see people in a whole bunch of different pathways, right? Like some folks might come in and say, "Oh, I hit my head," or
Yeah.
"I fell down," because falls are the number one cause of traumatic brain injury. Motor vehicle collisions are also up there as well. The sport concussion is actually has some of the lowest prevalence in the world of concussion, but it gets the most talked about because that's kind of like the sexy thing that people want to talk about are
Yeah.
sports.
Yeah.
But that's good because it's started a conversation and people are listening and are thinking about things differently. So I'm totally fine with that. So depending on the pathway in which the patient has reached me, whether it's an
Yeah.
acute concussion like that
Yeah.
just happened in the
Okay.
last day or two,
Let's say it just happened.
yeah, so I would, and really no different than the chronic, the persistent patient, but
Yeah.
I do a full exam on them. So an orthopedic screen, a neurological screen, so upper lower quarter screens. I check their head and neck orthopedically. I look at their eyes for ocular motor discrepancies, testing sensation, up and down just to make sure there wasn't any other more severe brain or spinal cord injury. God forbid, but we do see that from time to time. And then that wouldn't be classified as a concussion, of course. Um, and just take a full history. What was the mechanism? Like, what happened? And we know that concussion, you do not have to get hit in the head to get a concussion. So there are these things called sub-concussive blows, where
Yeah.
people can kind of get like body checked, like in basketball and hockey, or if you're in a car accident, you don't hit your head, but you have a very severe blow where your brain essentially gets shaken from the reverberation up. And then we can also have if you have a service member or if there is an explosion. So there can also be blast injuries. So really taking a full history on the patient from the mechanism of injury, looking at their body from head to toe, and screening all areas of the body. And then really learning about the patient pre-injury factors as well is so important to devising a plan and a concussion diagnosis.
Okay. So if they came in with a doctor's note saying this person had a concussion from a car accident,
Mhm.
would you treat them differently than what you just said? Would you do anything differently, or just jump right to?
Oh, no, absolutely not. I always appreciate a prescription, but most prescriptions we get are say evaluate and treat, or they do say concussion, and that's fine. But we
But
have to
stay.
take a full history on everyone that comes through, just because God forbid something was missed or not mentioned, and in this day of healthcare, most people are rushed. So you want to really make sure to take a full history on the patient, no matter who's referring to you. But it's always helpful to have another person on board to talk to in as a clinician.
Okay. Well, speaking of clinician, where do you work now? You're a lecturer as well, aren't you now?
Yeah, so after my injury, I left my company and of about 5 years, and where am I now? I'm a program director for what I believe to be the world's first concussion education program. And it's going to be a year-long program. We're going to launch in March. We're going to go public very soon and announce that. But it's going to, we have about 15 faculty and 15 guest speakers, and I'll be teaching and program directing as well. So I'm about as excited as can be
Yeah.
and busy as can be
Yeah. But
with that as well right now.
ah, so actually, what kind of so that's in New York or
Well, that's going to be with a fantastic company called Evidence in Motion.
Okay.
And Evidence in Motion is a wonderful company, and it's actually an online company. So basically, anywhere in the 50 states, someone can take this course online, and there'll be a 1 weekend intensive, and we're also going to offer it internationally as well.
So one weekend intensive, they go. I'll pick somewhere. You go there, and you can teach them manual techniques, or
Yeah, I'm going to basically review the psychomotor properties of what it takes to triage, treat, and manage a concussion patient. So, various testing, because the bottom line is, and really the bottom line, there's no evidence-based medicine for concussion. So people kind of have consensus statements and communication and case reports and case studies, and really don't know what to do with all the information because someone may be trained in neuro or ortho or vestibular medicine or vision, but the nature of a concussive injury is all encompassing. So
yeah.
you're looking at physical, emotional, cognitive, often sleep issues. So we have to make sure that we address that, and I'll be addressing it from a rehabilitative team approach. Specifically looking at deficits, looking at identifying temporal pathways of, addressing treatment, and trying to bridge that all together from an ortho and neuro perspective. So it's going to be a busy and a neat
Yeah.
program.
That sounds exciting. And actually, like I mentioned to you earlier, I watched the video of your presentation in
Mhm.
Denver, and you mentioned a fair bit about general screening, how you can be a specialist in one thing, but it doesn't mean you're good at everything. So, how important do you think general screening is for people who've had concussions? General screening for every area, as you just mentioned.
It's probably the number one most important thing. We really have to look at the patient as a person, and we have to look at all aspects of their life. Everything from their social, emotional, and we call this biopsychosocial model, where we're looking at the person, we're looking at their environment, we're looking at their injury, we're looking at what potential life and or social stressors they may be having. You know, a general screening is very important to um, identify early deficits like vision, which are generally tend to be ocular motor issues, um, vision, mood, behavior, balance, somatosensory things. Do they have an amnestic event? Are they
Oh,
dizzy?
what? Sorry, what of it?
Like an amnesia. They would call it
Okay,
an amnestic
amnestic.
event.
Okay,
Yeah. Do
I was
they
like,
remember?
yeah,
Yeah.
okay.
Do they remember the injury? Are they noise and light sensitive? Do they have fatigue? Are they just angry all the time? Can they concentrate? Can they remember? So really looking at all domains of what makes a person is so important when evaluating this injury, because you're not just treating an ankle. Folks really understand, an ankle sprain. So when I treat or talk or triage folks that call me up from all over the world, I completely remove the brain and remove that part of the conversation. And people tend to understand, like if they hurt a bone, bones heal about 6 to 8 weeks if there's no presence of any other abnormalities. So people get it, they see it, they can see a swollen ankle, and then they understand that, hey, we have to like get your range of motion back, and then we can weight bear to full weight bearing, and then we can start training in straight planes and then lateral cuts, and then we can jump around with plyometrics, and then you go back to practice and then gameplay. But a concussion is an invisible injury,
Yeah.
and people don't often understand that, and they often don't understand how it can affect your life as an all-encompassing injury. So really having a really skilled clinician to look at all aspects and that general screen that we're talking about is so important because we really want to set folks up for success in order to treat, refer as needed, communicate the referral is really important. You can't just refer someone out that has a concussion. You have to kind of give the referring clinician, a little bit more information to set them up for success. So there's a whole bunch of things that kind of go into a general screening.
So obviously this is very important to you because like you said, you've had a concussion. So what were your main symptoms? Your main issues you think from your concussion? If you
Yeah,
remember.
well, it'd probably be easier to say what were
Okay,
my
well, what
or,
ones?
no, no. That's a great question, Nick. So yeah, so I had headaches and migraines pretty regularly. I was dizzy and had balance issues. I did not like initially. I didn't like noise, so we called that. And then
I still don't.
yeah,
Really,
yeah, and that's
like
really
loud noise, like just kind of ridiculous, but there's
yeah, and
certain
that's
noises.
probably why you like to do Pilates so
Yeah,
much
yeah,
because that Pilates is something that soothes the nervous system. So our nervous systems kind of get all hot and bothered when we have a head
yeah,
injury. So anything to soothe the nervous system is so very important, from taking warm baths and warm showers to meditation, yoga, Pilates. You already tapped into some of those pathways that
yeah,
help you out. So yeah, light sensitivity. I had neuro fatigue was a big one for me as I started to become more functional.
yeah.
I was irritable, and it sucks being a woman and being irritable, especially me being a doctor of physical therapy, and knowing that I shouldn't be angry at someone taking my parking spot, and that I usually would be able to just kind of get over that in a few
But is
minutes.
it good? Was it a good parking spot though?
And I live in New York City, Nick. So, that's like fighting for your life there. So yeah, so all of those things, poor concentration initially, poor short-term memory initially, but I went through quite a bit of rehabilitation with neuropsychology and vision rehabilitation, which was huge, vestibular rehabilitation, and physical therapy for my head and neck, because I did have a whiplash injury as well.
Okay.
So yeah, I kind of went through it all.
Wow.
And I would say if I had to pick two, that my vision, my top one would be
Yeah.
my vision.
Vision
It's really my
sucks.
biggest issue.
Yeah.
Yeah, and you know that for
Yeah.
sure. So.
Yeah. Definitely. So, well, you mentioned earlier that you played a lot of sports in high school and still club teams now, but so yeah, obviously those issues sound like they really would have affected any sport, any athletics you were doing. But what did you play, or what do you still play or play again now?
Yeah, so that's another great question. So I was actually an avid cyclist, and that's where I kind of put my love in time, money, because being a cyclist is expensive. Those little
Yeah.
jerseys are tiny, but they're expensive. And the lighter your bike, the more expensive it gets. So I had a great full carbon bike, a Truck Madone, and it was cool because that was the bike that Lance Armstrong had. So I always felt cool when I hopped on it. So the day before I got hit, I actually did a 52-mile bike ride,
Okay.
and which was ironic that I made it through that and just sitting at
Yeah.
a red light. Someone's irresponsible behavior, texting and driving, kind of changed my life forever. So I actually do not bike ride right now. Bike riding is a TBI sport, and I know,
Neither do I. I don't
yeah,
because there's some bounce.
yep, and you're connected to that for sure.
Yeah.
So for right now in my life, I've put that on hold. I'd say that's probably one of the most personally painful things that I've had to kind of put a halt on because I
Yeah.
really do love cycling. So, but I do spin, and I go to the gym more regularly. Now and kind of get into a spin class. And I've just recently taken up some kickboxing, obviously protecting my head,
Yeah.
but like the classes with the bags, nothing crazy. And I've been really just appreciating nature. So I've been really enjoying hiking and getting out and going for a walk and just appreciating that I can do that now, because I wasn't able to do that before.
That's great. That's yeah, nature and just I've heard kickboxing is actually a really good workout. That's it.
Oh yeah, oh yeah. I
So
couldn't sit down for like 2 days the first
yeah,
day I did it, but it's great.
yeah.
So
Well,
it's nice to feel like an athlete again.
yeah, exactly. Well, thank you so much, Jess. Do you have any questions yourself, or if not, this has been a great chat.
Yeah, no problem. I always say if people want to find me, they can find me at Twitter at DPT to go, DPT like Doctor Physical Therapy, the number two go. And if you would like to email, please feel free. It's jessica@pt2go.co. And I'll be we're doing some launching the program for Evidence in Motion in March. So there should be some news and press about that in the next month or two.
And your website is PTO.
pt2go.co. Yeah,
Okay.
.co, not .com. Everyone looks for
Yeah.
pt2go.com, but yeah, pt2go.co. So feel free to reach out to me via that pathway as well.
Oh, great. Yeah, no, it's a great website. That's where I found their. Actually, I found your Denver presentation on your from your Twitter page actually. But
Yeah. I'm still working on my public speaking, so I'll be at the Pink Concussions conference. It's the world's first women concussion conference in February at Georgetown Med,
cool.
February 27th. So I'll be speaking there. So
Well,
I'll up my public speaking ante for that conference.
if anybody is going to be in Washington D.C., then check that in February. Check that out.
Absolutely,
But
absolutely.
yeah, so thanks so much, Jess. It was great talking to you, and thank you so much for your time.
No problem, Nick. I'll talk to you soon.
Great, thanks.
Take care.
Thanks again to Dr. Jess Schwartz. You can find links to her Twitter account, her website, and her EIM Evidence in Motion program, which will be announced in March, on my article for this podcast. Thank you so much for listening, and I hope you listen again in 2016. As always, music at the beginning of this podcast is by Ben Sound. www.bensound.com